So let me introduce Dr. Manson. It's a pleasure to bring him here. Spero Manson, Pembina Chippewa, is a medical anthropologist and professor of psychiatry and public health, distinguished professor. He heads the American Indian and Alaska Native programs at the University of Colorado at Denver and Health Sciences Center. His programs include 9 national centers totaling $65 million in sponsored activities, which entail research, program development, and training among 102 Native communities spanning rural, reservation, urban, and village settings. Dr. Manson has published 150 articles, probably going up from there, to 60 on the assessment, epidemiology, treatment, and prevention of physical, alcohol, drug, as well as mental health problems in the special population. He is a member of the Institute of Medicine. He has received numerous awards, other awards, that's quite an award in and of itself, including 3 Distinguished Service Awards from the Indian Health Service, the prestigious Rimala Post Mental Health Epidemiology Award from the American Public Health Association, and forgive me if I'm not pronouncing the names exactly right, 2 Distinguished Mentor Awards from the Gerontological Society of America, the Herbert Nickens Award from the AAMC, American Association of Medical Colleges, I'm assuming that's what it is, and the George Foster Award for Excellence from the Society for Medical Anthropology. Perfect speaker for us today. Thank you.
Thank you. Dr. Cohen, Dr. Valdez, thank you very much. I'm delighted to be with you today. I'm a walker. I just had my right hip replaced December 1st. So this is my 2nd week without a cane. And if I stand or sit for any length of time in the same place, I stiffen up. So I walk. But in the language of my people, I'm me, Boju. I'm Anishinaabe, which means the people, Pembina Chippewa from the Turtle Mountain Reservation. And my presentation is part personal as well as professional today. I ask you to remember at this point in time the number 292. 292. I will come back to it at the close of my remarks. What I'd like to share with you today is what I think is an incredible advance and a wonderful testimony to the creative energies and commitment of Indian and Native people in our battle with respect to, on one hand, preventing diabetes in our communities, and on the other hand, the reduction of risk for cardiovascular disease among those members of our communities who are already diabetic. Today's remarks address the former. Perhaps another time I'll have an opportunity to share with you their wonderful accomplishments in regard to the latter. Why diabetes? Diabetes because, and Catherine, I walked away from the pointer, and I don't want to come back that way the same. Thank you. Diabetes because it's of epidemic proportions in Indian and Native communities. In fact, as this slide reminds us, in 2009, the rate of diabetes for adults eligible for care from the Indian Health Service was was more than 16%. That's twice that among their non-Hispanic white counterparts. Also, too, we know that among American Indian Alaska Natives particularly, the greatest risk for the most serious complication is cardiovascular disease, which is costly not only from an economic point of view, but costly in terms of decrements in quality of life and the burden that it places on individuals, families, and communities. But particularly of note is this last bulleted item, coming from a recent study we completed that was just published in the American Journal of Public Health, in which we worked in the Phoenix Indian Medical Center. And for the 2-year period between 2008 and 2009, in reviewing their records and linking the utilization data with cost data, we were able to document the fact that nearly 11% of the adults with diabetes at that particular service unit, which is among the largest in the Indian Health Service system, accounted for 30% of the total health expenditures of all health dollars available at that unit, which is substantially greater than what we see in the country at large. So the economic consequences to the system of care are enormous. It was in 1997 and then enacted in 1998 that Congress took special note of this epidemic and the consequences thereof, when they mandated the formation and the funding of something called the Special Diabetes Program for Indians, SDPI. The first 5 years through 2002 was about $100 to $125 million a year appropriation that increased in time beginning in 1998. Was focused on mobilizing Indian and Native communities. First was to ensure that there was appropriate recognition of diabetes as a problem. One of the challenges is that many populations, particularly American Indian, Alaska Native, because of the high rates of some of these disorders and conditions, we tend to assume that it's destiny, that it is just simply part of our genetic makeup. So too, we've heard that rationale with respect to alcoholism in Indian and Native communities. And we hear it now, or have heard it, with respect to diabetes. In fact, perhaps you're not Indian if you're not diabetic. And so for those 5 years was this enormous focus on education, of getting out through a variety of mechanisms and ensuring that people were aware of the nature and extent of this problem, and that in fact it is malleable, that we can intervene, and that a difference can be made. So what we saw then was a recalibration of community attitudes and expectations and assumptions about the nature of the disorder, an increasing awareness of the nature of the risk for diabetes and of the complications, the costs, psychically and economically. At the close of the first 5 years of the funding of this appropriation, Congress was pleased with respect to the progress made. There were a variety of different indices of the increased awareness, the increased mobilization, the increased knowledge with respect to diabetes and its implications in Indian and Native communities. But it was seen as a necessary but not sufficient condition for really making a difference in terms of preventing this debilitating and chronic condition. So it was in 2002, for implementation in 2003, that Congress reauthorized the Special Diabetes Program for Indians. But in this particular case, it authorized it in two components. One was a continuation of the original mobilization and education campaign, which have become known as the community-directed programs, and the addition of a competitive demonstration project, which was intended at that point in time to bring forward and to test evidence-based practices shown in the general population and documented through the best available scientific evidence that the interventions in question could in fact make a difference with respect to the prevalence and incidence of diabetes and the risk of diabetes in these communities. And it became known as the demonstration project, and after its conclusion, we now are in the expansion dissemination of it. The dissemination projects, as I anticipated earlier, Mark, are of two types, one focusing on diabetes prevention, the other on cardiovascular disease risk reduction. I'm only today talking about the former, the SDPI Diabetes Prevention Program. It has 36 programs around the country. It's characterized by a collaborative approach to the development of the intervention activities, which spring from the, and I'll talk for a moment about the NIDDK Diabetes Prevention Program intensive lifestyle that this is modeled after. It includes as well a comprehensive program evaluation and a coordinating center, which I've had the privilege of directing, that has multiple responsibilities, primarily the provision of program development and technical assistance to ensure fidelity to the implementation of the evidence-based practices, and secondly, to undertake an extremely rigorous scientific evaluation of both the process and the outcomes associated with the application of this evidence-based practice. So that you can see here in this particular slide very quickly The diabetes prevention grantee sites. There are 36 of them, indicated in red, around the country, with the primary coordinating center located here in Denver. For a period of time, in the initial 5 years, we had another coordinating center in Arizona, headed by a former mentee of mine and subsequent co-director of the program, Dr. Yvette Rubidoux, who is now the director of the Indian Health Service. This slide does not show the other 30 cardiovascular disease risk reduction sites. The diabetes prevention grantee sites actually encompass over 80 tribal communities around the country. Just to give you a brief sense for the timeline of the demonstration projects, they were funded initially in 2003. In 2004, together with the Division of Diabetes Treatment and Prevention in the Indian Health Service, we at the Coordinating Center developed a request for applications to solicit, through a competitive mechanism, proposals from tribal communities, both rural, reservation, urban, and 501c3s serving Indian and Native people. Their applications to deliver and participate in the planning, implementation, and evaluation of the extension of the intensive lifestyle intervention that was originally developed in an efficacy trial and proven effective by the National Institute of Diabetes and Digestive and Kidney Disease, NIDDK. 2004 was a planning year, 2004-2005, which I think is really one of the hallmarks of this initiative, echoing, I think, many of the exhortations we hear about the importance of conducting community-based participatory research, although this is not research, this is actually health promotion with rigorous evaluation. And in that planning year, the 36 grantees, in this case over 80 tribal communities, met with our coordinating center staff and the DDTP from the Indian Health Service, that's the Division of Diabetes Treatment and Prevention, to actually take a careful look at this intensive lifestyle curriculum that had been proven efficacious by the NIDDK. In fact, so efficacious that they concluded the trial early, because to continue it on would have been unethical, which is a standard in most clinical trial work. And we thought through every aspect of this. We thought through the nature of the intervention, its content, its format, its delivery, had engaging and often vigorous discussions about the nature of the intervention. We planned together an elaborate and rigorous evaluation of it that I'll talk about in a few moments as well. That was multi-level. An evaluation plan that, interestingly enough, despite the initial angst about evaluation, was driven to a level of complexity never intended by either the Coordinating Center or the Indian Health Service because of the interest and the perspective of the grantees themselves. 2005 through 2010 was the actual delivery of this evidence-based intervention in a highly rigorous fashion. I'll give you a greater sense for in a few moments. And we, at the conclusion of its formal evaluation, have now shifted in our focus to not only continuing the delivery of the intervention, but into a major phase of dissemination and translation of this work into other sources that will enable the some 400 other Indian and Native communities around the country who did not have an opportunity to directly participate in a demonstration project to consider, adopt, and to implement this set of evidence-based practices. Now, what's this intensive lifestyle intervention? It's based on the diabetes prevention program known as the DPP. The DPP study found that it's possible to prevent type 2 diabetes in persons at risk through three things. Weight loss. And in the intervention itself, the goal was a 7% loss of weight. The second element of it is physical activity, of increasing the participants' level of physical activity through a variety of different means to a minimum of 115 minutes per week. And the third was to reconfigure eating habits to get a greater balance and emphasis on healthy eating habits as opposed to unhealthy eating habits. It was proven effective in the general population. It had over 45 different sites around the country, well representing not only the majority population, but Black, Hispanic, and there were 3 American Indian sites, largely in the Southwest, that participated as well. Interestingly enough, the American Indian sites totaled only 161 of some 4,000 participants. So the generalization of the results from those native sites was less confident than for their counterparts in the broader efficacy trial, but still mirrored similar kinds of gains. But nonetheless, once we complete these kinds of efficacy trials, becomes the enormous challenge of translation. How do these interventions that we develop in tightly controlled, well-resourced circumstances work when exported to the real world in which we receive our care, in which we live? That's the litmus test. That's where the rubber hits the road, and where many of the interventions that are initially evidence-based stumble. So it was that the Congress mandated that we adopt this evidence-based practice, intensive lifestyle intervention. I'll talk about the structure and format of it in just a moment. But the first phase of it was recruiting individuals from the participating communities. Let me talk about that in just a moment. Now, the 36 grantees that comprise the body of participating communities, numbering over 80 ultimately, represented in every sense the vast geographic, cultural, and demographic diversity that you might imagine is characteristic of Indian and Native communities. They represented all of the IHS service areas across the country. They spanned from Alaska to California, throughout the Midwest, up into New York. The recruitment efforts really drew upon the creativity and the naturally occurring networks that are so much a part of everyday life in these communities. Each program had, as a part of its terms and conditions, funded through this mandate, that it would commit and be required to recruit a minimum of 50 participants in each year. So in the period of time here, we're talking approximately 150 individuals that would be recruited to the program. To give you a sense for the first slightly more than 3 years, at the near conclusion of the formal evaluation in July of 2009, they had recruited 3,418 individuals into this intensive lifestyle intervention. I think we know for the most part from the literature that the biggest challenge as we translate evidence-based practices from trials of efficacy to trials of effectiveness is both the fidelity to the implementation of the evidence-based practice and our ability to recruit and retain participants in the program. This particular slide gives you a quick sense for the retention rates of the diabetes prevention participants in these programs. So that obviously at baseline was 100%. But at follow-up, which was 30 days post-completion of this 16-session intensive lifestyle intervention, the programs were able to retain 72% of the total at baseline. And you can see here that was 58% 1 year post-baseline, almost 50% at the end of 2 years post-baseline, and although the third annual hadn't been totally completed, it was about the same at the third year post-baseline. So actually, when you look at effectiveness trials and dissemination projects, really highly successful retention rates. And this is important because, as you'll see in a few moments, the greatest predictor of success was retention in the program. This particular slide reminds me that each of the programs, as a part of their initial recruitment efforts, developed a quilt a logo for their program, usually done through a local contest among community members, and then were stitched together, and this blanket, the resulting quilt, was passed from each grantee to the next as we meet on a quarterly basis. And the grantees themselves choose their successors, recognizing their various accomplishments. One of the hallmarks of this study that emanated from the first year, that planning year, was from the very outset, an emphasis on peer-to-peer learning and peer-to-peer teaching. So the challenge for us at the Coordinating Center, and continuing to push the Indian Health Service to agree to this, was to move ourselves into the background as quickly as possible, so that the programs themselves and their participants became the leaders, that they ultimately planned the conferences. They identified and orchestrated all of the panel presentations. They identified their training needs. They helped select the experts who had come. They drew many of the experts from their own programs. It truly became their initiative. And this was just one of those special ways to acknowledge the successes of each of their respective counterparts in the program. Let's talk a little bit about the intervention itself and its implementation apart from recruitment and retention. Now, the DPP, the Diabetes Prevention Program, it involves screening American Indian Alaska Native people with prediabetes. I won't get into the particulars of that. It uses impaired fasting glucose or and a variety of other measures to determine the eligibility of the individual. You cannot be diabetic. You typically have a family history, impaired glucose, etc. Weight, hip circumference, a variety of factors go into rendering somebody eligible or not for the program. One of the interesting challenges we had is there was such great success in the first 5 years of the SDPI with respect to increasing awareness and knowledge about diabetes that we had at least 30% of the individuals who sought admission into the program were not eligible for it because they didn't meet the pre-diabetes criteria, which we take as a hallmark of its success in terms of the initial recruitment. But you know, it introduced an interesting issue. How do you take that enthusiasm and interest and commitment and redirect it in a way without extinguishing it? That was a major challenge for the grantees, I think, that they actually addressed quite effectively. Now, the DPP, also known as the Lifestyle Balance Curriculum, is 16 two-hour sessions. It's not necessarily delivered on a weekly basis. It just has to be delivered within a 16 to 24-week period of time. Now, in the original efficacy trial, sponsored by NIDDK, the curriculum was delivered on one-to-one with a lifestyle coach as the deliverer, typically a higher order ancillary health professional who was well-trained in the curriculum, has a health background, and is connected in some way, shape, or form with the local clinic. Now, the diabetes prevention program, as it unfolded in this particular initiative, rarely was associated with the local IHS or tribal health clinic. In fact, one of the hallmarks of success was actually figuring out how to place the program out into the community, into non-stigmatizing settings. So the local churches, Boys and Girls Club, wellness centers, etc. But did you rarely ever find it implemented within the confines of the clinic itself. There was individual lifestyle coaching sessions, physical activity programs, and follow-up support to reinforce the curriculum. The curriculum was originally designed to emphasize the accomplishment of the three primary characteristics of the intervention I indicated earlier. One was to increase healthy habits, basically with a low carbohydrate diet. Secondly, to increase physical activity. And thirdly was weight loss. Thanks, Diane. Each of the communities developed a retention and an after-core. So there was a concerted effort at identifying ways, and this is where the creativity among the communities emerged, ways to keep people in the program. And there were ultimately, in the one paper that I circulated earlier from Healthy Heart, its companion program, there ultimately emerged 21 different categories of types of recruitment strategies with anywhere from 6 to 8 tactics within each of those. They ranged all the way from the typical ones of telephonic follow-up to home visits, to talking circles, to tribal leaders in the community going out, doing PSAs over the local radio or tribal cable television, etc. It was only limited by the imagination, creativity of these communities, which I found boundless. The aftercore was also characterized by a range of community activities, all the way from the traditional ones that many of us might be familiar with, such as health fairs or run walks or these kinds of things, but also in this particular case drew heavy in cultural activities as well. So that with many of the powwows or the traditional ceremonial dances, for example, there were special dances that were sponsored by the program. And if you've ever attended any of these kinds of ceremonial dances, you know how vigorous they are in terms of their demands physically on people, which was part of the idea. This gives you just a visual snapshot of it. The funds for the initiative allowed each of the grantee programs to either build or to enhance local wellness centers so that you could actually put up a double Y, dedicate it to a wellness center that had a cardiovascular, weightlifting equipment, et cetera, et cetera. So again, you saw a major infusion of these kinds of resources into the communities. It also allowed the community, with demonstrated need, to improve the built environment in terms of developing walking paths. One of the interesting and counterintuitive things is that we initially thought that the communities that had paved roads, we would see more walking and running and these kinds of things than those that had fewer paved roads. But the irony is that life in many of these rural reservation communities, particularly where there are paved roads, that vehicular accidents are quite common. So people avoided the paved roads and they went to the gravel, unpaved roads. So what we ended up doing was developing bike paths, walking paths, running paths adjacent to the gravel roads and avoided the paved roads. There were some wonderful lessons learned about this. The other kinds of things they did too is they actually did surveys of the local grocery stores. I remember at Navajo with the Bosch's stores, you know, there are a number of Navajo people in here, right? And Bosch's is one of the widely present grocers in many of the southwestern communities. Well, you know, there's a whole strategy, there's a whole marketing strategy to putting certain kinds of goods and foodstuffs up at the cashier's register, right? Are they usually the things that are good for you? No. So there was an effort in many of these communities to go in, work with the local grocers, identify what were unhealthy foods, and at least move towards a greater balance of healthy food alternatives up there at the cashier's desk, and actually begin to provide incentives to the participants and to the grocers to offer more foodstuffs that were recommended. So we had a series of primary and secondary goals with respect to the extension of the lifestyle balance or the intensive lifestyle curriculum from the DPP into these communities. The primary goal, of course, was preventing diabetes in people with impaired glucose or impaired fasting glucose. The secondary had to do with decreasing the risk of diabetes, approximating as best as possible that 7% weight loss, lowering BMI, body mass index, reducing waist circumference, increasing the physical activity to 150 minutes or greater a week, increasing the consumption of healthy foods, and decreasing the consumption of the unhealthy foods. Basically, many of the same outcomes that the original efficacy version of this had. Well, let me share with you some of the results. First, let's look at class attendance. I indicated that there are 16 classes, 2 hours in length. Remember, one of the adaptations that we made systematically without doing violence to the curriculum content was we shifted from a one-on-one to a group format. There was enormous concern among those at NIDDK about doing it this way, but when you get into the real world, in terms of what available resources are likely to be, you have to think about these kinds of things. So we were particularly rigorous in looking at implementation fidelity in a group format. Another thing that we permitted, because in Indian and Native communities, as it is in many other communities, given the nature of the behavior change that you're asking someone, I mean, I cook for my family. How do you think when I have my 16-year-old and my wife together that they're going to support and take to a major change in the diet of the family because dad's got to change the way he eats? Well, that's magnified in spades among the female participants who are often assigned the major responsibility of preparing meals in many of these kinds of households. So we encouraged family members to participate in the group classes too, which was a major deviation from the format of the efficacy trial, which only focused on the primary participant. Now, not all participants had family members participating, but over 70% did in at least half of the group classes. And I'll tell you now, I think that was one of the other major keys to the success of this initiative. And we had nearly 67% of the some 3,400 participants in this initiative attend all 16 classes. And just to break it up categorically, about 17% attended between 9 and 15 classes, and about 17% attended fewer than 8 classes. To give you another sense for the magnitude of activity, this bar graph shows you the number of lifestyle coach visits that actually were conducted, apart from the curriculum itself. So the lifestyle coaches were available to the program participants and family members outside of the 16 two-hour sessions to actually help them design an exercise program, whether it be weightlifting, cardiovascular, etc. They were available to counsel them, to problem solve, to support. Exactly what it was in the original efficacy trial. So at one point in time in 2008, and this is now continuing up to the present, nearly 10,000. Last count last year, we had over 14,000 lifestyle coach interactions with program participants. So an enormous amount of activity that is represented here. One of the other interesting things that occurred that never had an opportunity to unfold in the efficacy trial were the local community gardens. In the early year of implementation, first year of implementation, one of the grantees developed a garden tended by the participants of developing indigenous foods. It was actually one of the programs here from the Southwest. That caught on like wildfire, so that to this day, all 36 grantee programs have built in to their curriculum a community garden that involves not only the primary program participant, but family members and others that are a part of developing this garden. And it does 3 things. It underscores the message about healthy eating in culturally appropriate ways. Secondly, it's physically demanding, not inordinately so, but it provides yet another avenue for physical exertion. And thirdly, because it encourages family and community participation, it brings more social positive reinforcement into the mix with respect to the intervention itself. The after-core activities, that is, once you graduate from this 16-session intervention, are, again, also of substantial magnitude among the 36 grantee programs. So that in 2008, and this has continued to grow over time, and again, remind you that 2009 was only a 6-month period of time. So we're seeing people participate in all of these other after-core activities, these health fairs, these fun runs, the dances, all the other kinds of things that occur that are intended to keep people engaged, to reinforce and sustain the outcomes and the gains that were accomplished, and to bring more people into the mix, and thereby continue to change and recalibrate the community norms and expectations around diabetes, weight loss, participation in systematic interventions of this nature. Let's talk about the effectiveness of the intervention now. Our evaluation design, as I've said on several occasions, was quite rigorous. You know, I think as all of us are quite aware, we reached the point where anecdote and personal testimony before Congress may be necessary, but it's an insufficient condition for carrying the day with respect to justifying the continued funding of our programs or advancing the development of new funds. We have to have data, scientific, empirical evidence of the impact of our work. That was recognized at the outset of this particular initiative. So together during that planning year, we developed with our community partners and the evaluation that was required, fortunately, as part of the mandate by Congress. And this is one of the interesting tensions in Indian and Native communities. Indian and Native communities historically have been funded for these kinds of activities in a categorical fashion with basically at most a symbolic nod towards the importance of evaluation. In the absence of congressional mandate to formally evaluate this demonstration project, we probably wouldn't have been able to do much. So it became a point of leverage to insist on it. Even with that mandate, we saw among a substantial minority, but still a substantial number of the grantees in that planning year, enormous resistance to evaluation. Why? Two reasons. One is that they saw evaluation dollars taking away from service dollars. And secondly, evaluation is quickly equated with research in Indian and Native communities, which has with it a legacy that's not particularly attractive historically. But the congressional mandate, together with that planning year and the collaborative nature of the development of this effectiveness trial or demonstration project, moved us at least to the point where that vocal minority that were resistant agreed to suspend judgment about evaluation. And that was critical. And as we moved forward in the years, they became among the strongest advocates for evaluation because they had for the first time real data I'm about to show you that makes the case unequivocally for the return on investment. So our evaluation focused both on process as well as outcomes. Did the program successfully implement the intervention in a way that was true to the original curriculum within the limits? We talked about flexible uniformity. Sort of an interesting catchphrase about how we can find an appropriate balance between the implementation of this curriculum in a way as originally designed, but in a manner that is both socially and culturally, ecologically sound. One example I've already mentioned, group versus individual delivery. Another example is the permission of family members to participate in those group sessions. Another is the development and incorporation of locally meaningful activities like these community gardens. All right? It doesn't do trauma to the original content or format of the intervention. It actually enhances it. And then, of course, the outcomes. And the outcomes I have to share with you today are the short-term and intermediate outcomes. What factors are associated with successful participants in programs is the question. So the design was basically taking this recruitment and screening and consent forward into the baseline. I think there were 3,400 and some odd individuals at baseline. Into the 16 sessions of the DPP curriculum, I indicated that there were 72%, I think, that completed it, with about 67% completing all 16 sessions. There was an initial follow-up assessment conducted within 30 days of completion of the curriculum. There was then an annual assessment that was conducted within 1 year of initial baseline, and a second annual assessment within 2 years, and a third within 3 years of annual baseline. There was also, as you know, as I mentioned before, lifestyle coaching, community-based activities that occurred during this period of time in which we used a variety of quantitative and qualitative techniques to document. Now, as I said, and you probably know, most interventions of this nature focus on the primary recipient of the intervention, that is, the individual attending the courses, which I think is rather short-sighted because it doesn't take into account many of the other reinforcers, the factors that both facilitate as well as impede participation and that can compromise the possible gains. It was, in fact, the grantees themselves that advocated we needed a multi-level approach to evaluation. So that in addition to the individual, they insisted that we think creatively about measuring among providers, the program itself, the organization housing it, and the community itself. And we did that on a regular basis. The other thing we did was a cost analysis, because there's an enormous question that accompanies this about what's the cost benefit attached to this. So, the results of the evaluation project. Recruitment started in January of 2006. Data collection in the formal evaluation phase concluded in July of 2009 for most participants, and those recruited at the point of July 2009 obviously had just entered the beginning of the first year of their participation, so that we continued to follow them until July 31st of 2010. As indicated, there are 36 diabetes prevention program sites, approximately 3.5 years of evaluation activities that were done. Give you a little bit of a sense for some of the comorbidities characterizing this particular population. About 75% of them met criteria for metabolic syndrome, described in detail down here. There's been an enormous debate, sort of tempered a bit recently, about metabolic syndrome and its place in terms of risk of diabetes and the appropriate attention to it in terms of prevention. Well, we decided not to use metabolic syndrome as an eligibility criteria for admission in because the efficacy trial did not, and that was our point of reference. But as you can see here, this was a population, as you might expect from one that is pre-diabetic, that has a number of other comorbidities attached to it, near over 37% with high blood pressure, 35% with back pain, 18% disclosing substantial depressive symptomatology, 15% meeting criteria for osteoarthritis, etc. This is the key slide. This slide has 3 curves on it. The red dotted curve is the placebo group from the original NIDDK efficacy trial. It's here. This slide is incident diabetes over time. This is the y-axis with percent of diabetes observed over time, and this is the time axis. All right? So here's where the placebo group, or control, the incident rate of the diabetes over time for the control group in the NIDDK efficacy trial. The blue line was the intervention group that received the intervention in that efficacy trial, represented here. The green dotted line is our group in the demonstration, etc., and assigned item points, and came up with a total. You come up with a total risk score. The total risk score, for example, ranges all the way from less than 10 to greater than 25, with corresponding 8-year risk of meeting criteria for type 2 diabetes. Now, for every decline in one point of a risk score from 11 to 10, the evidence from Framingham is that you reduce the loss of productive years lived by 2. Okay? So if you reduce the risk score by 1, you add 2 years of productive life gained, if you want to turn it around. If you reduce the score by 4, you gain 8 years. Okay? Just crudely put. It's a little more complicated than that, but that's what it boils down to. Well, here's what we saw. The purple bar is at baseline, the risk score. This particular bar here was at immediate follow-up, that's 30 days post-intervention. This sea green, khaki color line was first annual, this is second annual, this is third annual. This effectiveness trial reduced the risk score significantly from baseline all across by, on average, 3 points gaining 6 years back on people's lives. 6 years. Again, equal to what they saw in the original efficacy trial. This particular slide shows you what the average weight at each assessment was. Again, set up the same way, baseline, immediate post-intervention, first, second, third annual assessments. Substantial weight loss, it was a little over 4%, but significantly different from baseline in each case. Now the interesting thing is when you go into the data specific to the American Indian participants in the original efficacy trial, you saw only about a 4 to 4.2% weight loss. You did not see the full 7% that you saw among the other populations. So we mirrored pretty much their experience with the Native communities. Lifestyle changes. What did we see in terms of the intervention's impact on increased physical activity, the consumption of healthy foods, and the movement away from consuming unhealthy foods? Well, again, substantial and significant changes in each case. We saw physical activity whereas nearly 60% of the participants met the goal of 150 minutes per week or more, and even 1, 2, and 3 years out, we saw substantial maintenance of that level of physical activity among these participants. Again, too, with healthy foods, we saw substantial change in the desired direction, and with respect to unhealthy foods, substantial change in the desired direction. Fasting blood glucose at each assessment, again, significantly different in the desired direction at follow-up and annually. Blood pressure and lipid levels at each assessment, not as uniformly positive, but pretty persistently across the board, particularly with respect to triglycerides and blood pressure and LDL, not so much with HDL. Health-related quality of life, again, here using the MOS short form, the 12-item version, and looking at the physical component, the mental health component. I might know that we've done a lot of prior work in looking at the psychometrics of this particular measure. It works quite effectively in Indian and Native communities. We saw substantial improvements in both individual perceptions of their physical health and the quality of life, as well as their mental health quality of life. Now, do you remember the number I told you at the outset? 292. January of 2007, that's what I weighed. And I felt it was sort of like fairly hypocritical to stand up with all of these communities and espouse this philosophy and the importance of doing all of this. So I undertook a public pledge that I would walk the talk, and I lost 110 pounds. Thank you. Now, as some of you know, I just had my hip replaced in December 1st of this last year. I'm at, month 3 now. And there's no doubt why I had to have my hip replaced, because I was carrying around 110 pounds for all of those years, combined with relatively athletic life and osteoarthritis, etc. And one of the biggest barriers to participation in seeing these kinds of outcomes is pain and its impairment, and it's as a barrier to participating in the physical activities. And I experienced that firsthand. I had been working out 4 to 5 days a week for an hour at a time on an elliptical trainer. I couldn't do it anymore. I gained back 16 pounds over an 18-month period of time. Well, when the doctor cleared me to go back, I started out my elliptical trainer. I'm walking a lot more, and I've lost 4 pounds of those 16 pounds. And it just reminds me, personally, of what we're asking people to do and the importance of empathy and recognition of the demands we ask of others. I'm also a big comfort food eater, In Indian and Native communities, the levels of stress are enormous. And if you know the stress coping literature at all, and you know about the HPA axis and the role of cortisol and adrenaline and the relationship of stress, both serious episodic stress and trauma, as well as chronic underlying stress, There are a variety of coping strategies and very clear physiologic bases for, high carbohydrate foods with respect to the production of insulin and the rewarding aspects of that. And here we are asking people, and I'll never forget, as one woman saw the dietary expectations built into the curriculum, you're asking me to give up the only thing that gives me pleasure for something that looks well beyond my reach. So I think it's really important as we professionally seek to discover ways scientifically and otherwise to bring about these changes in people's lives, that we appreciate the depth of the demands that are being asked, and that we do everything in our power to mirror their efforts. So, a remarkable testimony to what can be done. We heard all kinds of stories when this demonstration project was undertaken, that there was just no way. It was throwing, it's $150 million a year, about $28 million a year invested each year into this initiative, and the cost analyses are just coming in. They're really substantial in changing that ratio of total health expenditure dollars among this relatively small minority of diabetes patients. It also has enormous individual and family and community rewards. Thank you for your time.
So, I'm thinking about how various health promotion interventions have tried to be culturally relevant. There are a number of American Indian interventions that have been developed and then translated into specific tribal community contexts. So taking an American Indian intervention and turning it into a Navajo-specific intervention. Then there have also been interventions designed specifically for one tribe within its oral tradition and maybe using some of its language in a health intervention. It seems to me that the diabetes prevention program was designed in a way that enabled many tribal communities to tailor the intervention and make it culturally relevant to themselves in the way that made the most sense for them. And so I would be interested to hear your thoughts about this particular approach, because I think both the community empowerment aspects are unique. So I have two questions. Did the evaluation analyze how the lifestyle coaches, the recruiters, and the retention efforts, how these situated their parts of the intervention within local cultural frameworks? So not just having dances sponsored or at powwows, but as the intervention was delivered, were people translating the intervention material into their own local framework, perhaps making it a Navajo intervention as an example? And then will there be an opportunity to examine to what extent this cultural identity production informed the efficacy of the trial? Thank you.
Thank you. Well, it was interesting with respect to the first question. As I anticipated, that there was a great deal of resistance, not resistance, well, there was resistance. I think there was healthy skepticism, bordering on cynicism among many of us, but particularly the grantees in that first planning year, about the wisdom and potential for success of exporting this very structured, linear, 16-session life balance curriculum into their community settings. well-placed skepticism. But there were, I think, several things that forced everybody, and not just forced, but encouraged people to suspend judgment and give it a try. The first was Congress mandated it, and it controlled the dollars. So you could choose to apply or not. And the solicitation of applications was quite clear that there were a core set of activities about which there would be no choice in terms of adopting and implementing them. But there would be the opportunity to work with the manner of their implementation and to tailor their format to local circumstances, social, cultural, physical, and the like. That was important, and it provided the initial leverage to at least make sure that people engaged in the conversation. Because, in my experience, 3.5 decades, at that point in time, many people will just bail on it and say, look, that's just not for us. And, you know, some communities did by default in deciding not to apply. Others applied assuming that they might be able to change the circumstances, which proved wrong. But the second piece came into play, and that is that there were 3 American Indian communities that participated in the efficacy trial. So we brought in Native people from those 3 communities to serve as essentially champions. Champions not just simply of the intervention, but champions who were able to illustrate in terms in their own experience the flexibility that they discovered in the intervention. Not so much in the content, but it's in its format and delivery, and all the other secondary and supportive activities that could be mounted to support the gains likely to be realized. That went a long ways towards people agreeing to suspend the judgment. And the third thing was this planning year. As I shared before one of the earlier groups, I spent 8 a.m. to 8 p.m. every Friday for 2 years in the Psychiatry at Oregon Health Sciences University, and so came to appreciate the clinical endeavor and sort of the notion of reaction formation and transference and these kinds of things, and my own defensiveness. And one of the things that I and the coordinating center, we worked hard in the Indian Health Service to do, and Yvette Rubidoux was enormously central to this, is we were able to dampen down our own frustration and impatience with people's expression of concerns along these lines, and manage the process. But if we hadn't had a year to manage and work with the process and to hear and adopt in important ways and to demonstrate that we are open to hearing and adopting in important ways and I don't want to use the word feedback because these were equal partners during the tribal communities in this year within the constraints of the curriculum, the mandate. What then emerged quickly in the first year of implementation were the ways in which these grantees took the curriculum, took the intervention, and made it their own. And I shared some of those examples. And stepping back and having the grantees run the meetings and doing these panels, talking about core activities, about adaptations in the curriculum, healthy and necessary debates about what was reasonable and probably not reasonable in terms of adaptation to content and format. We had an enormous debate about inclusion of family members, for example, in the curriculum. And we talked to the people who at NNDDK, and they couldn't offer a good reason why not to, other than it hadn't been done. And we were quickly able to dismiss that as a reason for not doing it. And as these early examples began to roll in, I think, and the emphasis on peer-to-peer learning and peer-to-peer teaching, it was like, this diffusion, this rapid diffusion of these discoveries among the grantees, and not just wholehearted, uncritical taking up of what somebody else had done, but seeing the idea Actually, we at the Coordinating Center funded the travel of grantees from one community to another so they could share these kinds of things, and we had a lot of mechanisms for doing that. So it occurred as much as possible within the constraints of the original intervention in terms of its content and format with the fidelity measures, and we're able to speak to that. The second is the identity formation piece of it, and you know, it's really interesting in places like Tohono O'odham, for example, where nearly 75% of the community is obese. In my own family, I'm one of 5 boys. 3 of my brothers were diabetic. We were all morbidly fat. And I'm smiling to myself because I'm remembering, you know this Julio, the Iglesias, the Hispanic comedian, he talks about being fluffy, not fat. Well, you know, I remember going and getting husky jeans. And part of what this whole, it's a movement in part, is about was changing the language that we use and willing to use yourself as an example to alter the way in which you're talking about these things. And I mean it when I said that many people said, well, I'm fat because I'm Indian. And if I wasn't fat, people might wonder whether or not I'm truly Indian. I got to tell you, I've heard that over and over and over again. And I also know it in terms of my own personal, familial, community rationalizations for obesity. And until you get champions who are willing to speak out, and we've seen these in other areas, in alcoholism, in child abuse, until you get these champions willing to put themselves out front and say, look, there are other ways of doing this, and it's not non-cultural, that this sort of identity formation begins to change. The other key piece of it is, as a part of the planning, you're emphasized getting to key stakeholders, both formal and informal, early in the process. Spiritual leaders in the community, formal political leaders, of getting the Billy Mills of the world, who are the Olympic gold medalists, who are even slender into their later years, talking about these kinds of things and getting those kinds of role models available to people were really critical. And I hadn't thought about it so much in terms of cultural identity reformulation, but there's a big piece of that. And you see it in the materials that are published. I think the 3 things that are shown. You know, I mean that's a great photo. That photo right there has got multi-generations in the background on the lower right, emphasizing the sense of connectedness. It's got this obviously obese woman, but smiling and publicly exercising. These things are often, if ever, if done, they're done surreptitiously without an audience, these kinds of things. So there are lots of ways in which I think identity formation is being reworked through initiatives like this. So those are great questions. Thank you.
Dr. Manson, I have to say this is very exciting research for those of us who care about disparities, and I can tell that there's a bunch of people in the room that are very excited about it. My question kind of builds on something that you mentioned this morning to those of us who had the pleasure of your company, where you talked about understanding people in the context of their lives and the environments in which they live in them. And you mentioned a lot about the individual behavior changes that this project is focused on. And you briefly mentioned that you gained some knowledge from your participants about family level, community level, and macro level interventions. And I would like you to expand on what your team learned from the participants about these environments and contexts that they think will, what changes need to exist in these or needs to happen in these for them to maintain this individual behavioral success.
Thank you, Dimitri. It's not just with respect to weight loss or recovery if you're alcoholic, or if you're sort of antisocial in other ways. And the message you typically get is that your maintenance of your gains is a matter of character. The ability to maintain what you've accomplished resides within you and entirely within you. And I submit to you that that's the frequent message we get. And if you step back and think about it, while appealing to a certain extent, because it plays to our sense of the importance of self-efficacy and will and character, which are very deeply ingrained in many aspects of American life. Among Indian and Native people, part of being connected, going back to Dorinda's comment, is part of the identity formation. So part of what this intervention is about is a rediscovery and a reaffirmation of who you are as a Native person, not on the basis of your individual participation in this, but because of the involvement of family and community in a variety of different forms. The lessons learned from this, in the 15 minutes remaining, I can't even begin to recount, but except for any intervention that is singularly focused on individual behavior change and individual self-centric coping skills, I think is much less likely to have long-term sustainability. If you think about it, in the examples I gave, the built environment alone. Before, I got involved in this a decade ago, I never really thought systematically about the importance of built environment. But that example I gave about the roads and sort of the counterintuitiveness of it, it just really drove home the importance of literally the built environment, not just the availability and access to a wellness center, which is an important piece of part of the built environment, but the other ways in which the built environment contributes to it. I gave the example of the groceries, the grocery stores and the suppliers. It's part of the built environment. We don't necessarily quickly think of it as part of the built environment, but it is also malleable and subject to change. We just have to be creative about it and figure out where the points of leverage are and how to flex the muscle to pull the lever. And that lever often is economic, which means that in several of these cases, this is a great story, because I remember I visited just about every grantee in both arms. And I remember I always sit down with the participants and talk to them about the nature of the successes that they've had and what were some of the barriers and facilitators of that success. And I remember that it was the husband of one of the participants was there, and he got up, and I thought he was going to punch me out. He said, "I want you to know, I've been wondering who was responsible for all of the shit," and that was his word, "all the shit I've had to put up with my wife being in this program for the last year." He says, "I have not been able to get a decent meal. I have had to go and leave work to go pick her up, da-da-da-da." And then he smiled and said, "However, I want you to know I just joined the program." And it reminded me of the fact that we're asking major changes among social networks and constellations that when we think in a singular individual-centric fashion that we can no longer afford to if we want to think about, one, long-term success, and two, the diffusion of success across the community. Lots of other things were really driven home to me. I remember being in front of one of the tribal councils, and it was on the other initiative, the Healthy Heart Initiative, which has to do with reducing the risk of cardiovascular disease, a consequence of diabetes. And so I'm there in the tribal council, and their 12 members are right here, and I'm reporting to them at their request. And the no smoking placards are laid all out throughout the tribal council chambers, but 4 of the 9 members there are all smoking. And I come to the smoking part of the agenda of the presentation, and I said, "My guess is that you 4 are not part of the Healthy Heart Program, although you might be eligible. And one of them looks at me and says, well, why? And I says, because you're smoking, particularly in a building that says no smoking, and then engaged in a debate about, role models of leaders. And so, the importance of leadership, whether it be formal or informal, reinforcing the positive messages to begin. I mean, how long did it take to get no smoking codes in these buildings? Well, that's a necessary, but it ain't a sufficient step, right? To move it forward in terms of the enactment of these kinds of things and why. So understanding the importance of leadership at multiple levels was, I think, one of the great lessons learned. Another one, and I mentioned it briefly, was the reconfiguring of the attitudes and expectations that have been historic about grant programs. Here they were, this started in 2003, it's still going. It's still going, a decade later. These communities are used to these 2 to 3 year kinds of interventions. Oh, by the way, 6 months in the project, you've been funded and your progress report is due in 3 weeks. You're now at 2.5 years, and yes, you just got started recruitment, but now you have to think about wind down. So we have been conditioned to think short term. So one of the things that has occurred was watching people and programs and communities begin to free themselves up to risk thinking longer term. Because it is a risk to think a little longer term about these kinds of things. And that's another, I think, second and third order factor that really became apparent. I just could go on and on and on, but there's so many lessons to be learned. And I think these are lessons, Dimitri, that bode well for other preventive interventions, regardless of the disease or condition of focus. And now 10 years later, I find myself saying, gee, that's so obvious. And when you reach that point, I think you realize that you've learned something. So thank you for the question.
I have a question about native foods. Food is such a big part of our culture. Before a ceremony, we feed our people, we talk to them, and if we want to have something done, or if you want someone to conduct the ceremony, you go to them with food. To what extent did you use native foods, and did you have to adapt, centuries-old recipes and things like that? And I know regionally there's just it's a very diverse kind of menu. So that's my question.
It's a great question. And yes, that was an issue. And in some of our communities, the food giving or gifting is unilateral, and others it's bidirectional between both. And so we had lengthy discussions around the content of the curriculum about food, because you're right. You go and visit somebody, and you're immediately, they pull out, somebody was bemoaning the fact that Hostess is going out of business because there would be no more Twinkies and Ding Dongs. And, but so one of the things that the participants in the programs brainstorm about, and now there's a whole component that's been added to curriculums about how to address these kinds of things by taking foods with you to offer it to others, and how to, how it's very offensive not to obviously partake of food given to you by somebody, even if it's ding-dongs and yo-yos, ho-hos and everything else. So how do you tactfully manage those circumstances? It became a part of the curriculum, added to it, because you needed to have those kinds of coping strategies. And then, of course, the preparation of traditional foods. Fried bread really isn't a traditional food. And getting people to think outside the box about, well, gosh, if we're going to have indigenous foods, how does fried bread fit into this? Well, it doesn't necessarily, but if you're going to have fried bread, there are ways you can prepare fried bread that are more healthy than they might otherwise be. And so there are lots of discussions and sharing. That's what the whole peer-to-peer teaching and peer-to-peer learning piece of this was, the sharing of these discoveries across the various communities about how to anticipate, recognize, and find culturally appropriate alternatives to those circumstances. So, great question. Thank you.
Great presentation, and thank you very much. I have one comment, one question. The comment is I'm very happy to hear a lot of this. I'm working on a project with male colorectal cancer in Hispanics, and we're looking at two things. One is pulling in the whole family and having some questions about that from NCI for funding, so I'm very glad to hear some of your arguments with that. We're also looking at community gardens, so I'm interested in talking to you further about that offline. But my question is, look at those comorbidities and cancer being just 1.4. Were any in your participants, though, was prevention of cancer a motivator for any of them? How much was that on the radar screen?
No, it wasn't. It wasn't because, well, first off, we had to be very careful about mixed messaging.
Yeah.
So we decided staying singular and focused on diabetes, which also was consistent with the previous 5 years of public education campaigns. We wanted to build from that. It's not that there wasn't appreciation that, you know, in many of these communities, the rates of cancer are high and climbing, and that obesity and other kinds of factors are now coming out as risk factors for that. We felt that we were on much less solid ground in terms of educating people about those kinds of connections, as well as using it as a point of recruitment into the program. It's not, and it's, you know, there's enormous concern about cancer in many of these communities. So we had a lot of discussion about what the priorities ought to be in the messaging around this. And Wendy, you're a communications expert, and so you, I'm sure, can appreciate about the challenges you face in terms of selecting your priority and being having a consistent message in this regard. So we had a very explicit and conscious discussion about this.
Because we're looking, you know, at some of the literature about metabolic syndrome, you know, connection to cancer and that type of thing. Although the molecular epidemiology, I don't know if there's any in the room here, would speak against that, because while we're looking at that behaviorally and risk factor wise, and are looking at different designs and programs around that way in both ethnic communities and Hispanic communities based on requests we've had for the correlation between the two. Yet I know some of the, I guess it's called molecular epidemiology and biology is not as clear. With diabetes, you know, that's more clear. With cancer, while the obesity and lack of exercise is correlations there, we don't have the clear molecular biology pathways for that. But we're more and more are looking at combining that, so I was just curious on your thought with that.
And the other thing is, for us, is looking down the road. Those kinds of possibilities are there. We've not precluded them. They've just not been part of the initial emphasis. The other big piece of this is you recognize in these economic times, there are enormous policy implications. So we're busy now with this demonstration of the effectiveness of it, thinking about dissemination and also thinking about policy implications, because now the next level of challenge is institutionalizing this in the other 400 and some odd community-directed programs that had not been previously mandated to adhere to an evidence-based practice. So I think, although it occasioned substantial discussion, I think it was ultimately the right decision to say single-focused, because it built in the prior 5 years. Carolyn, and then you?
I may have missed it, but what was your age range?
Oh.
And was it large enough to look at outcomes, including retention, across those age ranges?
Yeah, 18 years and older, there was no cap. We had a 92-year-old participant, for example. And we have a manuscript coming out on retention with respect to DP, but we had one published in the Gerontologist on retention in the cardiovascular risk reduction arm of this. And there are a variety of individual, provider, and community factors that were related to retention. And older age among the individual dispositional factors was positively associated with retention.
Dr. Mason, Dr. Valdez, and RWJF and putting this on. My question is, how does, like, I guess, how does special programs like these address the fact that even like Native Americans across the border, at least here in New Mexico, have access to some of the greatest, or not the greatest, but have better access to diabetes prevention, diabetes programs, diabetes treatment, but how does programs like this help address the fact that Native Americans are still, I think it's twice as likely to die from complications to diabetes?
The answer to that is in the other arm, which you're talking about the serious complications and risk of those complications if you're diabetic. And in fact, that, if you remember the third bullet point on the first slide showing that about 10.9% of the IHS service population in Phoenix Indian Medical Center were diabetics, and they consumed 37% of the total healthcare expenditure, it's due to the complications associated with diabetes. I think there are a variety of things to understand that I've tried to deal with. One is sort of goes under the rubric, under the heading of help-seeking behavior. You know, if you're 292 pounds and your brothers and sisters and family members are equally obese, and the other members in your family are similarly obese, and they're struggling with the attendant comorbidities, there is an inclination to assume that this is the way that life is. And so we talk about it as passive forbearance. It is something to be, it's a burden to be borne, and it's just the way it is. It's just another life's burden. And it's until I think you are privy and have access to public examples, whether it's in your own immediate personal life or in your social networks, of people who've made this transition and shown you in a sort of a role model-like way that these kinds of changes are possible with great benefit, that you're, I think it takes things like that. One of the other motivators for me was a very poignant one to lose the weight, in addition to the public demands. It was my 16-year-old. He said to me, you know, Dad, I have two older children, a 33-year-old and a 30-year-old, and I have 4 grandchildren, 11, 9, 7, and 5, by my eldest, my daughter. And I've been able to do things with them, but at that point in time, increasingly less. I ride horses, I have a ranch, and I couldn't get up on my horse. So I would help them, and my son would watch, my 16-year-old watch that, and he says, you know, Dad, I'm really worried. And I said, well, what about? And he said, I'm worried you're not going to be here to help my kids learn how to ride and enjoy the ranch. And so that was another personal piece of the sort of the complexion of factors that led to my motivation. You know, in some places there isn't the access to these resources. You go up into Alaskans, many of the 212 small villages up there, the resources are not substantial, and particularly either to prevent, much less treat, the sequelae of diabetes. The system itself, in terms of cost and cost expenditures, the highest rates of end-stage renal disease leading to dialysis are found among American Indian people, largely because of diabetes. Amputations are astronomical rates among Indian and Native people, largely because of the consequences of diabetes. So what happens in the help-seeking behavior process, because of maybe the stigma, because of the lack of resources, because we don't recognize the potential serious nature of this, we're much more likely to seek help later in that process, if it is available, than others might be. So I think there's a constellation of factors, and again, you know, I'm always struck, talk about lessons learned, there's no single causative factor to these kinds of things. And it really underscores many of the things that your programs are about in terms of being interdisciplinary. I don't think the answers to these things reside in endocrinology, in nursing, in anthropology, in sociology alone. The insights, the tools, the solutions reside in part across those disciplines and ultimately within the communities themselves, and figuring out how to mobilize the communities so that they can take advantage of those tools. So thanks for the question.